Good afternoon, everyone. Thank you for joining us. This is Raquel with the Center of Excellence here. We have Dr. Adrienne Morgan and Yolanda Sayres to present on cultural humility. This webinar will be recorded and available after today, along with the slides if you wanted to share with your staff or listen for a second time. I will pass it over to Dr. Morgan to start the presentation.
Good afternoon, everyone. We're very excited about presenting and working with you today. Yolanda and I worked very hard to put together a very engaging, interactive webinar, and we really look forward to your participation. Again, my name is Adrienne Morgan, and I'm the Assistant Dean for Medical Education, Diversity and Inclusion at the University of Rochester School of Medicine and Dentistry.
And I am Yolanda Sayres. I'm the Outreach Coordinator for the Healthy Baby Network, which is a part of the Mitch Grant here in Rochester, New York. Thank you all for joining, and we're really looking forward to the objectives that you guys are going to learn today. And this webinar will review the definitions of cultural humility and present its relevance for the community work. As we work to provide the best opportunities for women with various needs and different socio-cultural backgrounds, it's very important to recognize that we cannot be experts or competent in all of the cultures. However, we can utilize an approach of cultural humility to interact with populations that we do not belong to and that we're not familiar with, whether it be economically or socially. Cultural humility is necessary for bridging the social, economic, and/or cultural gaps between health and human service workers and the community that they serve. And this webinar will provide you with specific strategies for working with various populations in the field of maternal and infant health.
Great. So our learning objectives for today are to define and understand the concepts of culture, stereotyping, cultural humility, and cultural competence. We're going to identify how to incorporate cultural humility as community health workers or home visitors through practical application. And we're going to highlight capacities and skills necessary to work effectively across diverse cultures. We'll begin with a refresher on the concept of cultural humility, and then we'll use the chat box application, or you're welcome to unmute yourself or to participate in the discussion. And also please feel free to raise your hand and we will unmute you to engage in the conversation. We'll also be doing some case studies, and we'll engage in a reflection exercise and then recap our learning. We will end with a question and answer session. So first we want to discuss stereotyping and how making assumptions about your client based on race, culture, or sexual orientation can hinder the interaction between community health workers or home visitors. So a stereotype is an oversimplified, generally over-exaggerated belief that all members of a certain group act and think in the same fashion. Individuals use negative stereotypes as a basis to justify discrimination and racism. But individuals may also use positive stereotypes to make claims that certain individuals in a society are better than other individuals. So at this time, is anybody willing to provide an example of a stereotype? Feel free to type in the chat box or to unmute or raise your hand. We all have stereotypes. If anybody willing to share one.
Oh, great. So we have from someone, every Dominican eats plantains.
Plantones.
Plantones. Great. Thank you.
Thank you. Thank you for sharing that.
Thank you.
So other examples of common stereotypes.
We got another one. Excellent. Thank you. That all Mexicans have a lot of children. Again, another stereotype. Thank you.
Great, thank you. Some of the stereotypes that Yolanda and I came up with are that all Jews are stingy, that all African Americans are good at sports, that all models are anorexic or bulimic, and that people on public assistance are lazy, and that Muslims or Arabs are terrorists. We all know that none of these are true. So think about stereotypes associated with your own cultural identity. What emotions do you feel about these stereotypes? And how can your feelings that you experience about stereotypes associated with your culture be applied to the work that you do as a community health worker or home visitor. So think about those. So when someone said all Mexicans have a lot of children, how does that make you feel? Or any of the other stereotypes that Yolanda and I came up with.
Now remember, this is interactive, so we're looking for you guys to respond to us.
Anyways, I just wanted to let you know to be by the fact. Yeah, I'm on a webinar until 2:30 already.
She's muted now.
Great. So someone said that it makes them upset because it places everyone in one category. It would make an individual feel upset. Absolutely. And it doesn't seem as if someone wants to get to know you individually. That's a great observation.
Yeah.
Thank you very much.
Thank you.
We really appreciate the input. So one of the things that we want to make sure is that learning culturally specific stereotypes can be potentially misleading for healthcare workers and detrimental to your clients. Cultural competency training has traditionally involved memorizing culturally specific rules for each group. For example, Muslims don't shake hands. Although learning about a particular group's cultural norms can be helpful, it may also lead to stereotyping and false assumptions. Because we are caring for increasingly diverse populations, including growing numbers of immigrants and refugees, there are too many cultural groups and too many norms to become familiar with. So please think about your client as an individual and not as someone as part of a larger group. So rather than learning to identify and respond to sets of culturally specific traits or stereotyping, a cultural humble or culturally collaborative community health worker or home visitor interviews the client and explores similarities and differences between his or her own clients and the priorities, goals, capabilities, and approaches.
Thank you, Adrienne, for those explanations and stereotyping. So we're going to talk about culture. But before we begin the conversation on cultural humility, we want to define culture and understand the key components of cultural identity and how it impacts our values, practices, and our own beliefs. This is a simple definition of culture. Culture is a learned pattern of behavior and the thought that help a group to adapt to its surroundings.
However, we can expand that definition. In this definition by Tyler, culture includes knowledge and actions. Culture is a set of guidelines, both explicit and implicit, that individuals inherit as members of a particular society and that tell them how to view the world, how to experience it emotionally, and how to behave in it in relation to other people. Simply put, culture is learned, shared, and exists within groups. Culture is not static, instead it evolves over time. People may belong to or identify with more than one culture and cultural community. So think about your own culture and think of how do you identify as an individual within that culture. I mean, you could be a woman, but you could also be African American. You could also be cisgender, or you could be homosexual, or heterosexual, homosexual. How many ways can you identify yourself? Some people just want to talk about that or type it in the chat box. How do you culturally identify? There are many ways. This person says, for me, I'm white. I'm a white female. Exactly. Thank you. Any other observations that people have about how they identify? Add to that, I am a nurse. Great. Thank you. So as we see, as we carry ourselves to the world, we have many, many ways to identify ourselves. I'm a native New Yorker. I love it. Thank you. Thank you. Okay.
So next we're going to explore the importance of cultural competence and cultural humility. Cultural competence in the health profession is about being responsive to meet the diverse cultures, their cultural health practices, and the languages of the people that we serve. Bintercourt, Green, and Cirillo actually define cultural competence in healthcare as the ability of systems to provide care to patients with diverse values, beliefs, and behaviors, including tailoring delivery to meet the patient's social, cultural, and linguistic needs.
So to sum up, in healthcare, cultural competence is about historical and legal standards, which include mandates, laws, rules, policies, standards, practices, and attitudes used to increase the quality of interactions within the public healthcare system. For example, many of you are familiar with the Hill-Burton Act that was enacted by Congress in 1946 that encouraged the construction and modernization of public and nonprofit community hospitals and health centers. In return for receiving these funds, recipients agreed to comply with the community service obligation, one of which is a general principle of non-discrimination in the delivery of services. The Office of Civil Rights has consistently interpreted this as an obligation to provide language assistance to those in need of such services. I'm sure most of you are aware of Title IX of the Civil Rights Act, which requires that institutions providing services with funding from the federal government must be delivered without regard to race, color, or national origin. Also, the national standards are culturally and linguistically appropriate services, or CLAS, which is a set of national standards for culturally and linguistically appropriate services issued by the U.S. Department of Health and Social Services of Minority Health, serves to ensure equitable and effective treatment to all people using the healthcare system. So when we think about cultural competency, we really are looking at things that have been done by government to ensure that people get quality care regardless of race, socioeconomic standard.
And so now we're going to take a look at cultural humility. And what cultural humility is, it incorporates a lifelong commitment to self-evaluation, to critique, and redressing the power imbalances in the physician-patient dynamic, and to develop mutually beneficial and non-paternalistic partnerships with communities on the behalf of individuals and the defined populations. Therefore, humility in the sense is not being weak or submissive, but you're going to actually have a sense of that knowing one's own knowledge is limited to as what truly is another's culture. We are limited because we have our own unconscious stereotypes of others and tend to use stereotypes as a safety net to help explain the behavior. Although we are part of this community of learners and community health workers and home visitors in training, there are many different experiences, values, beliefs, and identities that are present. Each of our cultural identities and beliefs shape how we view the world. We tend to see our own cultural identities, values, and beliefs as normal or good or right, and then sometimes we try to impose those on others. But one of the important factors that we as community health workers and home visitors must understand is that cultural humility is a unique framework for moving us toward equity. It's the philosophy that addresses the role of power and privilege in a system, as well as the imbalanced power of voice and power to make decisions. For example, as a community health worker or home visitor, you have power over your clients, or you can have the power to help some of your clients achieve their health goals by actually meeting them where they are and then setting aside your own biases and your own assumptions. Ultimately, what we want to be is culturally responsive and responsible with our in our interactions with our clients.
So since cultural humility strives to achieve equity in the healthcare provider and patient relationship, you as community health workers or home visitors will need to be willing to give up and share the power. This is referred to as transference of power. So transference of power is the desire to fix power imbalances where none ought to exist. So recognizing that each person brings something different based on their experiences and culture helps us to see the value of each person. When practitioners interview clients, the client is the expert on his or her own life, symptoms, and strengths. The practitioner holds a body of knowledge that the client does not have. However, the client also has understanding outside the scope of the practitioner. Both people must collaborate and learn from each other for the best outcomes. One holds power in scientific knowledge. For example, you have that power, and the power of the resources that are in the community. And the other holds the power in personal history.
Ay, corté.
So we have some cultural humility questions, right? And cultural humility matters because it can improve a CHW's or a home visitor's ability to work effectively and respectfully with their clients from all different backgrounds and experiences. And anytime you work with a client, there's a power dynamic that's going to be present. So cultural humility upholds an individual or a community group as the experts and teaches on the content of the personal culture. Cultural humility asks that we meet each person where he or she is by suspending judgment and resisting the need to impose our personal values, beliefs, truths, and notions of right and wrong. And so by doing so, we reduce the harm of prejudice and oppression and open opportunities for equity. We want to meet each person where he or she is, and we want to challenge and naming the assumptions and our biases. Sharing the hidden rules of success and redefining the cultural norms are part of deepening you as a community health worker and the home visitor, deepening you as the individual and strengthening your relationships with your clients. So take a moment and think about the following questions. Who has the most power in the CHW or home visitor-client relationship? And you can answer that in the chat box or unmute yourself. We'll take maybe one or two Yep. The visitor, I believe the client does, the visitor and the client. Very
So
good.
when you say the visitor, do you mean the home visitor or do you mean? Okay,
That's where the
visitor.
client is vulnerable.
Right.
Yep.
So you're saying because they are coming to someone's house where the client is vulnerable, the mom. Okay.
Yep.
Great.
Thank you. Second question, how might a CHW or a home visitor or other provider assert power over a client? And then also, how might that power dynamic negatively impact the client?
So again, how might a community health worker or home visitor assert power over a client?
Absolutely. Thank you. We have an answer by speaking over and not listening. Absolutely.
By deciding when to address certain needs. Exactly. Thank you. Not allowing the client to determine what the needs are. Absolutely. Thank you. That's very important. And again, how might that power dynamic negatively affect your client?
The client might become too dependent.
Very good. Thank you.
Feeling like they can't disclose vulnerable information. Absolutely. Or they might disengage. We do find that often that the clients do become disengaged and not want to take responsibility for their health goals.
Right. Or they may not want to participate at all. Again, showing no interest. Exactly.
Won't want your services because they feel that you don't value their opinion.
Absolutely.
Thank you. Thank you, everyone. So if you are living, you as a CHW are living these principles and practice cultural humility, you recognize that your client has the most power in the CHW or home visitor client relationship. They are the experts on the health and how they want to achieve their health goals. You are the knowledge expert, and therefore you can use your expertise to draft a health plan that meets the client's health goals that are based on the individual cultural beliefs and identity. Not listening to and respecting your client's belief can have a negative impact on your health, on their health, and your relationship with the client. And that's when someone said they might disengage. You as a CHW or the home visitor, it's very important that we are listening. And when we're listening, we're respecting that client and what they have to say.
So again, what we've really been talking about is really the balance in the relationship between the community health worker, home visitor, and the client. And again, going back to the transference of power concept. So I want you to take a moment to reflect on the issue of transference of power. So what do you think about the idea of transference of power? How do people feel about it? Do they feel that they are able to give up some of the power in this relationship between the client and community health worker or home visitor? Do you think that makes you more vulnerable? Any thoughts?
I know we can walk into meeting with a client and just walk in and think that we know everything. But again, if we're not listening to serve that individual at that point in time, we have the power and we're not allowing that transference of power to happen and for that individual to come up with their own health goals and us just being there and helping to assist in drafting that information for them.
So we had somebody say every client is different and you need to tailor the program to fit them.
Absolutely.
Exactly. And that's what that transfer of power does, is that it allows you to listen and engage with your client in a way that helps them meet their health goals. In the end, is better to do because they do not become overly dependent and you are treating them as an adult. Absolutely. Thank you very much. To read the full quote, it says, it's definitely not easy to do initially when you feel as though you have to be successful in terms of what referrals and needs are met. In the end, it is definitely better to do because they do not become overly dependent and you are treating them as an adult. So letting your client have a say in how they want that health plan or those resources or referrals to happen is very important.
Absolutely.
So we have another person who said, you have to keep in mind that is not what you think is best for the client. The client is the expert in their own lives.
Absolutely.
Thank you.
Thank you.
So again, how might it change the way you work with your clients, this transfer of power? How might it change the way that you work with them? Accountability, absolutely. Can you elaborate a little bit on that? Somebody said, or it could ease the stress on the home visitor. Okay, absolutely. It could ease your stress because you're really trying to do what's best for the client based on what they are willing to do and what they are willing to follow up on. They will want to succeed in the program and accomplish their goals exactly if it's coming from them and they're responsible for their own needs being met, and it teaches them that. Great, thank you. So giving up that power really helps your client to be accountable. It also helps them feel like they have had a part in the plan and they're more likely to follow through on that plan.
Absolutely.
So some people are reluctant to give up power, but by recognizing that your client plays an integral role in their healthcare and health choices, you must be open to listening, respecting, and working with them to achieve their health goals. Recognizing the individual beliefs of your client and partnering with them aids in the community health worker and the home visitor client relationship, and most importantly, helps to build trust. I also like that someone says, generally, if the client determines what their needs are, they work harder. Absolutely, thank you. So we all aspire to cultural humility rather than competence because competency implies an endpoint or mastery, while humility emphasizes the lifelong commitment to understand diversity. Key points of cultural humility include a self-reflective practice by examining one's own cultural backgrounds. So, as you move through life, you'll be on different ends of the spectrum of cultural humility, but you always need to come back to this self-reflective practice to determine your own cultural background. You also, reflection involves the continual challenging of oneself and an openness to learning from those we serve. Cultural humility also requires a knowledge base concerning the worldviews of various communities and the willingness, again, to be open to the worldviews of others. In addition, it requires power sharing with communities, recognizing them as experts of their own experience. Also, most importantly, cultural humility emphasizes avoiding assumptions based on stereotypes or insufficient knowledge of communities. And lastly, it requires the skills needed to collect relevant social and cultural data regarding the ideas about the way the world works and their role in it.
Thank you, Adrienne. So now we're going to go into some case studies, and then we're going to think about how you would approach these case studies using the principles and the practices of cultural humility. You can do this if you're in a group together, or if you're individually, we would ask for you to use your chat box to answer as a CHW or as the home visitor. These case studies are here, but they're there for you guys to use in your own agencies as well, for you guys to continually to build your skills up in using these case studies. You can practice them at any time. And we encourage you to use these skills of the lifelong commitment of cultural humility. So we're going to move into case study number 1. And we're going to provide you the information from the client's perspective and then from the CHW or the home visitor perspective. In the first case study, your client Sheila is a 19-year-old Hispanic female who is 3 months pregnant and moved to the United States 5 months ago with the child's father. They both speak English very well. Since being in the United States, they have moved 2 times and have not had any prenatal care. Sheila's family is very religious and does not believe in prenatal care, and Sheila feels that she does not need it either. The father of the child is currently in between jobs, and the only source of income are the benefits that they receive. They are currently residing in a high-crime neighborhood and would like to move again before the baby arrives. Sheila is experiencing some abdominal pain in which she believes is caused by the stress and will go away when she moves into a less stressful neighborhood. Sheila and her husband are both excited about becoming parents. And so you as the community health worker or the home visitor, you're Sheila. She was referred to you by the social worker at the Department of Health and Human Services. And after your initial intake visit, you're visiting Sheila for the second time, and she tells you that she hasn't had any prenatal care since being here in the United States. So your task is to assess what is keeping her from seeking prenatal care and what are her expectations for a healthy pregnancy. So using your chat box and what you've learned, take the cultural humble approach. And how would you advise Sheila and her husband? Thank you. Ask about previous experiences with medical providers.
Yeah, I think this is really important because if they've had a negative experience, they may not necessarily be willing to seek help from medical providers.
I would ask Sheila about her cultural practices with childbirth and prenatal care. Absolutely, especially if we're talking about having Sheila, we want to find out her goal and her expectations of having a healthy baby. Identifying close by medical providers, maybe they'd like to be a more holistic approach. Doula, midwife are examples.
Excellent, thank you.
I would also ask for information in her words, not in the words of others. Can you explain a little bit more about that? Explain if they'll be more comfortable with Spanish-speaking provider, although they both speak English very well. And I would ask them what their thoughts are on prenatal care and what they know about prenatal care. I would explain to them the benefits of prenatal care and let them know if they are interested, I could help them find a provider that would be right for them. Another one, someone else said they may feel more comfortable. Also explore experiences of other women in their lives.
Excellent.
Yeah, that's the centering pregnancy.
Yeah.
And maybe those experiences have influenced her own. Thank you. You guys are giving some awesome answers here. And this some of the highlights.
So this person that we asked to expand a little bit, yes, I'm talking about her point of view. Often we hear a lot from others when we meet a client and don't take the time to listen to her thoughts. Thank you for explaining that more.
Yeah, absolutely.
Yeah.
And I would try to assess how their religious beliefs impact their thoughts about prenatal care.
Very good.
And maybe the client would say her family doesn't believe in attaining care, but I would ask what she thinks. Absolutely, we want to hear from Sheila. That's the most important thing. We want to hear Sheila's thoughts. We want to know what Sheila's thoughts are around prenatal care and her birthing plan. Someone also did say they may be looking at a holistic approach, doula and midwife, but the most important thing is that we're establishing boundaries. And someone just said realistic expectations of what a healthy pregnancy is for Sheila. Connecting her with the Spanish-speaking physician, she may feel a little bit more comfortable. And then centering pregnancy to where she's around women that she may explore experiences of other women in their lives, and centering pregnancy may be something that Sheila would like to be a part of. So explaining that to Sheila as well. And then we definitely want to make sure that we follow up with her because she's not receiving prenatal care. We don't want to let too much time lapse in between Sheila and us visiting her. And because we want to keep the relationship going, but we also want to try to encourage her to seek prenatal care and having her come up with some sort of plan as well.
We also want to make sure that Sheila has access to all the benefits that she needs, particularly in obtaining that prenatal care. So whether that's WIC, SNAP, Medicaid, whatever that may be. And we also may want to help the husband engage in opportunities to find some kind of employment so that when they do get ready to move, they have the funding and support that they need to be able to make that move. So I think everything that everybody has said so far has been great. Thank you very much.
Absolutely. And definitely one last thing just to add is that to acknowledge that Sheila and her husband are happy about having this pregnancy. And I think that's really a jumping point that we can continue to feed off of their expectations of having a healthy pregnancy. Thank you, everyone. So now we're going to go into case study number 2. And again, you are the CHW and home visitor. Your client, Sasha, is a 35-year-old female from Somalia and has 1 child. She has been in the United States for 12 years and has had very little medical care and no birth control. The last time Sasha went to the doctor was because she was having really bad headaches. Sasha went to the emergency room, and while there, someone told her to leave and go back to her own country. Sasha made up in her mind that Western medicine and that the people in the United States are not friendly. She is now experiencing these same headaches again, but much worse than before, and she thinks she might be pregnant again. Sasha reluctantly goes to the emergency room. While there, she tells the doctor about her previous visit to the emergency room and how that made her feel. The doctor asks if she has medical insurance and proceeds to treat her. Sasha tells you, the CHW, about her experience and the stress that she's been under from her visit, and she does not want to see any doctor in the United States again. So you are the CHW or the home visitor, and Sasha was referred to you from a social worker at the emergency room. You're told by the social worker that Sasha was rude, possibly pregnant, and possibly delusional about her emergency room visit. Your task is to find out Sasha's experience at the emergency room and if she's willing to take a pregnancy test. So you can use the chat box for your thoughts.
Or please feel free to unmute yourself or to raise your hand. We'd love to hear some voices.
No, negative. That's what she's the bottom. Be good, man. Can you
Oh,
tell?
Wow,
There
you
you
guys
go.
are awesome. Thank you.
Can you tell me a little bit more about your emergency room experience? I would offer to make another appointment for her and also offer to accompany her, very good, and advocate for her. And offer individual and emotional support regarding the experience, very good. Absolutely, we want to find out Sheila's experience in the emergency room without re-traumatizing her because she potentially may be pregnant. And so accompanying her and advocating for her is a great way to show Sheila that you're caring for her.
Great. So someone else says, I know it's challenging navigating the health system. I'm sorry she went through that. Thank you. And I would probably start and explain who I am and ensure that I'm the person who won't judge her and that you're a safe person to talk to.
Absolutely. Creating that safe space for her and acknowledging that she did go through something, that's awesome. Thank you.
Also, to ask questions about why she believes she is pregnant and discuss other ways she can access care and offer to accompany her. I think that's a great suggestion. I think making sure that she's connected to a primary care physician and OBGYN and doesn't need to utilize the emergency room is a great way. So making sure that we have helped her access all the benefits that she has and being able to not have to use the emergency room as a place.
Right.
To receive care.
And maybe even potentially see if we could find a Somali doctor that she may be more comfortable with, and then someone in the Somali community as well. Maybe finding medical providers that speak her primary language and is familiar with her culture. Absolutely. And this can provide the support and also help with understanding what's going on. Look for other providers and start from there. Very good. Awesome. Someone wrote, explain that going to a clinic is different than going to an emergency room. Absolutely.
And also find out what she knows about the needs of women who are pregnant is a great suggestion. And support her by asking about her culture, and how to address her headache. Excellent.
And again, also ensuring that she has all the benefits that she's eligible for.
And also that centering pregnancy, again, would be a great opportunity if she is pregnant. And then how would people suggest we convince her to have a pregnancy test to ensure that she really is pregnant? Any suggestions on that? I also like that someone says affirm her for coming to still get assistance after her experience. Thank you. This is great. Most importantly, share that a CHW will help with researching different providers and clinics, schedule appointments, and accompany if needed. That's great. So that may be I think that's a great way to see if we could convince Sasha to have a pregnancy test.
Absolutely. Yeah. And providing those different resources for Sasha outside of the emergency room is great as well. And I think reaffirming her and letting her know that you're going to be there with her throughout this whole entire pregnancy, if she is pregnant, and letting her know that you are there and that you do care. Most importantly, share with the CHW will help with researching different providers and clinics, schedule appointments, accompany if needed, and offering a free test. And if positive, encouraging the follow-up to ensure baby and she are healthy. Absolutely. Yeah. Thank you.
Those are all great. Inform her of her rights if she is not aware. That's a great suggestion. Thank you.
Thank you. So we'll go into case number 3. And again, remember, you guys can use these in your agencies to practice your awesome skills that you learned here today. So Isla, case number 3, is a 20-year-old Syrian immigrant who delivered her second child 3 months ago. Isla has dreams of going to school and becoming a nurse one day. And she would like to try birth control, which is not welcome in her culture, and her husband is against any and all forms of birth control. When she mentioned birth control to you during your last visit, her husband became very upset and kicked you out. Because you and Isla are very close, she shared with you that she would like for the two of you to discuss with her husband the possibility of using Mirena. So you have been with Isla since her first pregnancy, and you both have become close, and she trusts you a lot. You know all about Isla's dream of going back to school and pursuing her nursing degree. And Isla, in your previous visit, hinted about exploring birth control options, but during the visit, her husband became very upset and asked you to leave. And now your task is to find out their thoughts on birth control and have a conversation with Isla and her husband. Let's see if we can get someone to unmute to speak to us. Is there a brave soul out there?
Or someone can type into the chat box as well. This is a great case, a very complicated case.
Mm-hmm.
So you said, learn more about this or his reason why she shouldn't be on birth control.
The conversation needs to be with Isla alone. I do believe that the initial conversation needs to be with Isla alone, absolutely. This case does have multiple layers.
Discuss power and control. True.
Educate her on birth control that he could be on board with. Someone else will, and assess if there are other places in her life where I think you believe you want to say he is controlling.
Yeah. But if the wish is to include her husband, I would respect that too.
Absolutely.
And determine what are the concerns regarding birth control. This might be a great time to do some research on your own around some cultural practices from Isla's culture to see if there are opportunities that women, where there are circumstances or opportunities where women can use birth control. Educate her on data regarding unwanted and unintended pregnancies would be great. Oh.
Maybe see if there's a partner organization that works with men from this community and work together to have conversation. That's an excellent idea.
And ask what exactly angered him and what his concerns are.
And then you also want to make sure what are her concerns about engaging her husband since he became so upset last time. Engaging her husband in the conversation about using birth control. Does anyone have any ideas about how you would begin to engage her husband in a conversation about using birth control?
Well, someone said encourage her to talk to her husband about their family life as a whole. For example, can we afford a baby at this time? Do we have the support?
That's very good.
That's great.
Someone wrote, I would ask Isla if she has shared her dreams with her partner. Awesome. I would ask her partner what his thoughts are about it and why he's opposed. I would ask him if he is aware of her plans for the future. I would educate him about birth control, as perhaps their culture does not believe in procreating unless it's desired. So explaining to them that they are controlling their future. That's excellent. And it's an excellent definition of cultural humility, letting them know that they're in control of their future.
It's interesting that someone said, I feel Isla is our client, not her husband. Could you expand on that a little bit? So if Isla is asking you to help engage in that conversation with her husband, what are your concerns about not coming to her? So Isla is the one that came to us in confidence. She did, but she has also asked us to help her engage her husband in a conversation on birth control. And so how would you address that part of it? If your client said, I'd like for you to help me talk to my husband about this.
And you're right. Someone wrote, it sounds like she wants support. Absolutely. I think someone said it previously, that we have to acknowledge that Isla has a dream and to share her dreams with her partner, and that by us addressing her and her husband in a conversation and letting both of them know about her dreams, that we are there to support her. And we're giving the power back unto her because we're sitting with her husband and her, and Isla's able to be open to her husband about what her dreams are.
Although we can't control what happens once we leave, it is important to provide language and support that can help not put her in danger, as he was upset previously. This is an intimate situation, and we need to honor that and keep safety at the forefront.
Absolutely.
Very good, thank you.
And I would ask him what he would do to prevent an unplanned pregnancy, especially if they are against abortion or any other procedure. What would he do if an unplanned pregnancy occurred?
So engaging him around his beliefs and attitudes about pregnancy and unplanned pregnancies.
And this is a great opportunity for the CHW or home visitor to come up with a plan as well. You can come up with a plan on how to proceed with this conversation. And then after the conversation, you can proceed with the plan on Isla's goals. And then if both come into agreement for the party on an unplanned pregnancy, you can come up with a pregnancy plan, right? You want to plan your pregnancy. So there's many opportunities for you to have multiple goals with Isla and her husband.
So again, the person who said, I feel Isla is our client, not her husband. Given the discussion that we've had, do you feel differently about that? And if not, or if so, why? Okay. The other thing that we might want to do is Isla's dream and desire to become a nurse. We could introduce her to other women within her culture that are nurses and be able for her to get a perspective from other women who are Syrian immigrants and see if they've achieved the level of becoming a nurse and being able to talk to them, and maybe her husband and her and that person can engage in a conversation.
Absolutely. And if there are any other benefits that she and her family are eligible for, we definitely want to make sure that they receive all the resources that they need so that we can continue to provide support to Isla.
Any other thoughts on this case from people? We'd still like to hear people's voices. Okay, thank you very much.
Thank you.
We appreciate everyone's input. These are great ideas. And we hope that you'll continue the conversation and dialogue around the cases as you move forward. So now we'd like you to take about 5 minutes to think about your last client or patient encounter. And using the principles of cultural humility, what would you have wanted to do differently? What would you have wanted to do differently in the last encounter you had with your client as a home visitor or as a community health worker?
And I say, you know, sometimes it's maybe not even our patient encounter. Maybe it was something in life that happened,
Absolutely.
you know, that, man, if I could go back and change what I said, what I did, I would do that a little bit different than what I did.
Okay. So maybe led. Oh, okay. Thank you.
This person said I should have asked the client to elaborate on a situation that was bothering them. That's great.
So I'm going to assume that you wrote down what they said and that was the end of it, but not necessarily digging a little bit deeper into what the problem was, but you went probably automatically to a solution. And then that problem probably had multiple layers, and then not giving them that opportunity to really express what was bothering them, letting them have that outlet. We can all identify with that. Is there anyone else out there thinking about their last patient encounter and what would you have wanted to do differently?
Yes, exactly. Thank you. So, Yolanda, you read that one right. You've obviously been in that situation before. That's great. Thank you. Anybody else want to just join in to say anything else? I would have liked to explore more with Dad what he currently does to care for his baby and how he perceives his role in caring for his baby. That's great.
Yeah, being a dad is its own culture.
Yeah,
you know, and they have their thoughts on fathering and our thoughts on how they should be the father are totally different. And so absolutely, we want to explore with Dad, especially if Dad is present in the home, finding out his parenting role and how he's perceiving his role as dad in the home and caring for the baby. Absolutely.
And that's so completely based on the culture too.
Absolutely. Absolutely.
So offered more positive reinforcement on how hard they are working given the situation they're in. Yes, your support, your positive thoughts and reinforcing that they're doing a great job is really important to them. I think it sends a very positive message to your client.
And even if it's the little things, and even if they kept their appointment, right? Because sometimes we have so many clients that cancel. If you're walking in there and you're saying, thank you so much for keeping your appointment. I really appreciate you meeting with me today. You know, if you carried around little gold stars, you remember in 5th grade, we used to get those little gold stars. I'm telling you, those little positive reinforcements, they go a long way because you're building that relationship and you're being sensitive unto that individual because anything could have happened. They could have canceled that appointment, but really reinforcing that positive. And it's just the little things that you're pointing out to that individual that's going to put that extra notch of trust inside of your client relationship. Someone wrote, I spoke to a client over the phone, and sometimes I know as a CHW home visitor, we feel like we have a lot to do. Checking in, so to speak, and dotting the I's and crossing the T's, that I get so excited, if you will. That led me to talk a little more rather than listen, because she was going to tell me anyways. I feel that I have a checklist going on in my head where I have to check things off, so I sometimes have to slow down. I did catch myself and centered the conversation on her. You're absolutely right. Sometimes we walk into these situations and there's 25 questions that you have to get through an initial intake. But During that initial intake, we want to allow that individual to speak. We want to give them that opportunity to talk. We want to give them that opportunity to have an open dialogue with you. Eventually, you will get to your dotting your I's and crossing your T's, but you want to begin to build a relationship first. That's first and foremost important. So I'm so glad that you caught yourself and you began to center the conversation back around her. That's a great skill to have because not many people have that skill. So kudos to you.
And over the phone can be difficult too, to be able to read how they're hearing you and receiving what you're saying.
Absolutely.
Thank you.
Thank you. Thank you, everyone.
So as we conclude the session on cultural humility, we would like to remind everyone that cultural humility is a lifelong practice and commitment to self-awareness and reflection. It requires being curious and open-minded about clients and having a genuine interest in understanding what approaches to health promotion will work best for them. Be aware of your own tendencies to want to rescue, lecture, direct, or control the client. Do your best to interrupt these impulses and get out of your own way. Breathe, listen, be willing to challenge your own assumptions and beliefs about what you think are the best or right ways to achieve the goals.
That's very good. Remember that cultural humility is a lifelong journey, not only with your clients, but this is something you can use in everyday practices. Each patient encounter will be different and it'll be unique. As you continue this journey, remember to acknowledge your own barriers to true intercultural understanding. Understand the difference between intellectually knowing another culture and being able to truly relate to it. Examine and suspend your own assumptions and beliefs about a group of people. This requires self-reflection, awareness, and critique. Don't be afraid to ask coworkers and supervisors for feedback, and also don't be afraid to do your own research.
Lastly, explore where the client and family are in their culture or their subculture. This requires active listening, flexibility to negotiate, and acceptances of differences. Most importantly, accept help in the process of learning about your client's culture. This can be achieved by simply asking him or her directly or by seeking out community members who can provide insight. Recognize that cultural humility is a process, not a cure-all formula. It is a set of skills or tools, and it will not solve all cross-cultural or family problems. Understand that cultural humility makes you ask questions about what you know and what you don't know.
And at this time, Adrienne and I are happy to take any questions.
Again, happy to hear your voice. If you want to unmute or raise your hand.
And if any time you have any questions regarding cultural humility, please feel free to contact myself or Adrienne regarding it. And, you know, if you wanted to enhance your skills a little bit more and just have a conversation, again, don't hesitate to contact either one of us. You're welcome.
Thank you.
Someone said this was helpful. Thank you.
So it says, I do not have any questions, but this was good. Good, I feel. I wish this was like an audio I can hear every day, like brainwash. I mean, that in a good way. Thank you.
We're going to be in your ear. You can hear us. Cultural humility, cultural humility.
Well, the recording will be available on the website, so you can go there and listen to it anytime. Are there any additional questions in terms of the terminology and definitions that were presented at the beginning of the webinar that maybe you want to hear more of or like defined further?
I think a big takeaway is don't beat yourself up. You know, this is hard work. This is lifelong work. And so, again, remember that every time that you meet a client, there's so much to learn. So don't beat yourself up if you don't get it right the first time. The process is to keep coming back and trying again.
Wait another few seconds if there are any last minute questions or comments.
So someone said, thank you so much for helping us think about this important issue. Thank you. We really appreciate it. We really enjoyed it. And thank you for all your hard work and participation. We know it's not easy sometimes to chat in, to use the chat box, or there's bravery issues about talking, but we really appreciate the hard work that you all did to be very engaged and to ask great questions, to have solutions to very difficult situations. We really appreciate that.
Absolutely.
So at this time, I want to thank the presenters. Thank you so much for your engagement and your interactivity with the participants. There will be an evaluation survey that will be sent out to you all. I strongly encourage you to complete those surveys, as it gives us feedback on this webinar, to repeat it again next year, and anything else that you want to know, want us to provide to you in terms of other webinars. So please complete those as you receive them, and have a good afternoon to you all. Thank you.
Thank you.
Thank you very much.